like I said, this meeting is being recorded. So the recording I'll make available on conference after. So I know there's a number of people that have contacted me that couldn't get here this evening. So we'll make it available after, as indeed we'll make the presentations available afterwards. So I'd like to welcome everybody to the second clinical webinar. So this evening we have two guest speakers, one who'll need no introduction whatsoever, which is Sophie, no I'm just kidding, which is Charles. So Charles Gutteridge works with me and Jane and Peter Hemler, so he's the clinical engagement lead for EMEA. And one of Charles's compatriots, I'll call her, which is Sophie Williams. And I'm going to let Sophie introduce herself because Sophie and I have never actually met, be it in person or virtually. So first of all, I'm going to hand over to Charles, who's going to tell you everything there is to know about the One London project. So I'm going to stop sharing and then you can grab the screen, Mr. Gutteridge.
Okay. So let's, do I have to press something like share screen?
So share screen should be on the bottom of your screen.
Yeah.
Which is the green thing.
Yeah.
No pun intended. Excellent.
So have you've got somewhere, have you?
So
I've got a rather annoying dialog box saying continue. Okay, right. I think I'm nearly there.
You're good. So just, yeah, that's the one. You're on.
Okay. So welcome everybody. My name is Charles Gutteridge, and some of you may have come across me, but many of you won't. So I'm an old guy, and I'm the Chief Medical Information Officer, or the Chief Clinical Information Officer, as we call them in England, for a group of hospitals in East London called Barts Health. I once was a practicing hematologist, but I've stopped practicing medicine, and I just focus on the informatics part of my world now. And I thought it would be of particular interest right now, actually, to tell you about a information system that we've been developing and building for some time in East London. And so I've called this presentation Information Models from Sharing to Analytics, because in a sense, that's how the story starts. Oh, sorry. I see. So it's much slower. And I thought I would start with something a little bit personal. I'm bunkered down in the countryside, protecting myself and my wife from COVID. And in the village in which I live at the moment, about a mile away, there's a stone, which now has a sign next to it, and it explains what it is. It's the Semley Plain Stone. I live in the village called Donnyd St Mary. And in the time of the Great Plague in England, in the 1660s, this stone was the information point, essentially. So villagers who were less badly affected in the surrounding countryside were instructed actually by the sort of local council, local government at the time, to leave notes, to leave information about how life was outside, and food and gifts and so on for the poor people of Donnyd St Mary. So in case any of you were wondering whether this is the first time this has ever happened on Earth, I think we all know that pandemics are actually quite common, and that the principles of social distancing and keeping apart from each other were established literally hundreds of years ago. moving about 400, 500 years ahead, this is the hospital I work in. And the rather curious photograph is not two photographs superimposed on each other. There is a modern hospital behind with a helicopter pad on top. And the old hospital of the Royal London Hospital is being rebuilt and is the empty carcass that you see in front of you. Huh. Just behind that wall, there was a plague pit. And so again, in the 1660s, when patients in what was then a rural part of London, there were cows and animals more or less where were looking. A plague was dug, and anyone who died of the plague was chucked into the pit there. And when the new hospital was being built, the plague pit was excavated, and every skeleton that was found was sanctified and reburied in somewhere else in London, or else kept in a mausoleum for study. It may interest some of you to know that the Elephant Man lived in the top floor of the empty old building that you see, and that this hospital has been associated with innovation and discovery for hundreds of years. And I want to tell you about the next chapter of that innovation, starting from this hospital. And the things I want to talk about are how we all should think about recording the signals from the real world and to create a computable semantic record. And to some extent, I think one thing we all have to do is to kind of look down the spiral of our lives and see it as a kind of stepwise up or down, where events that happen to us need to be ordered in a easily extractable way, rather like the steps or the balustrades in this spiral staircase, which comes actually from a lighthouse in France. But we need to be able to find the data about the events in our lives. But at the same time, and I think this is one of the things that the COVID-19 pandemic is showing us, we're not very good at understanding or knowing about the social determinants of health. And Henry Mayhew was a writer and sociologist in the 1880s and wrote this book, London Labour and London Poor, describing the life expectancy and lifestyles of labourers in London, ranging from fishmongers to costermongers to every profession and job type that there was in London, and associating it with where they lived and what happened to them. And that bit, I think, of our medical records is not very strong at the moment. It's worth thinking a little bit about what do people think about when they think about their health. You know, when you get up in the morning, you probably say to yourself in one way or another, how am I? Am I feeling okay? And if you get a tick, you get up, get dressed, and do whatever you're going to do. Sometimes you will correspond with your family in doing that, saying, what do my family know about me? And as long as all is well, you probably don't share your darkest or greatest secrets with them, but sometimes you will do. Sometimes you'll maintain the secrets because you're fearful and ashamed of them, or you share them because you think somebody will be able to help you. And as that sort of carapace of thinking develops over the day, you might ask the question, what do others know about me? Do I need to tell other people about me? Do I need to socially distance myself? And all of those sort of questions. And then finally, I think, over the last probably 10, 15, 20 years of my medical life, people are beginning to ask the question, what is in my record? And there's one way, this is one way of sort of conceiving of developing a conceptual model of the things that might be in a health record. And I certainly think the situation in England covers some of these things, but not all of them. So a record will have the demographics and the name, the providers who are providing health, the locations of those providers and the organizations. There may be a health profile that's relatively easy to find. Most electronic health records, I think that's not the case, and it's unusual to find good data about the social determinants of health. We're unbelievably good, at least in the West, of having a log of the health interventions, the products and services that we've offered either as clinicians or as healthcare organizations. And the simple reason for that is that's how we get money into the system and we can charge for it. So we're incredibly good at listing stuff. And I hope over this talk, I'm going to show you how that works and why structured data and how we collect data is important. And then in some electronic health records, there are healthcare plans that have been agreed and developed with patients about what they need to do to keep themselves well, objectives for health, and so on. And I would say, in general terms, we're atrocious at that part of what a health record might look like. And it's a great pity because, of course, if we were good at that, we might not be in the situation we are now. There's one part of the record which I think we're not bad at around healthcare planning, at least in general practice and primary care in England, and that's in logging and showing how people have been vaccinated. So we have quite good records for that, but lifelong plans for keeping fit, keeping healthy, losing weight, preventing diabetes, dealing with the risks of inherited and longitudinal disease, we're not particularly good at. I think the last thing that when thinking about human beings and discussing their health with them is developing a vocabulary that means something to everybody involved, doctors, nurses, the patient themselves. And so developing that vocabulary, making it multidisciplinary, easy to navigate in whichever form you're giving it, making sure it's comprehensive and computable is one of the challenges. We're here tonight because we're all believers in SNOMED, and I think SNOMED does cover some of that, but I guess navigating the SNOMED international browser might not be something that every citizen in the country does in an easy way. But I can see how we might provide data to people in a consumable and computable way using the principles of SNOMED and ontologies. I think there's one last thing I want you to, before I sort of get into the nitty-gritty of the data, is just for you to think about how one uses data extracted from an electronic health record for benefit and doing it in a governed way, protecting people's information. So I've sort of blocked this into two arrows of fortune. One is one needs to think about the societal context, making sure that the way you do this, there is a strong people focus and the people understand what you do, that there is a regulatory environment where the extraction of data from electronic health records is agreed with the people whose data it describes, and where the protection of people's personal information, the dark secrets that I described at the beginning, are properly kept secret if somebody wants to keep them secret, and that there's data security from a technical point of view, and that we have clearly set out ways of getting and asking and recording consent for the use of records in ways that benefit people. There's also another part of this, obviously, is that there is a clinical context to this, which one needs to be certain that there's something in real-world data that is useful, that it can describe elements of disease prevalence, whether there is or isn't a treatment effect that is of value to patients, and that what doctors do or what nurses do or what therapists do for patients is ethically okay. And so there are two sort of big blocks of questions. Is if the data you put in into an electronic health record is there, that's not good enough. One needs to know that the data are of sufficient quality to do something useful with. And I'm hoping Sophie, when she talks, will talk a bit about this in our thinking about some of the research studies that are underway at the moment in East London. But one needs to be certain that missing data in the record are minimized wherever possible, that the data are reliable and valid, and that built into your system of developing the data, there are established data quality procedures, and people are checking on a regular basis that the data is consistent. Because, of course, what we think of as data as human beings is not what data looks like or feels like or is anything like actually deep down in a database. One day when I have more time, I'll tell you my discussion about normal forms of databases with some of the people I work with. And then the other side of this is, if you're going to do studies using the data, you need to be certain that your methods are rigorous, regardless of whether it's a study looking at observational or interventional techniques in medicine, whether the data is a forward look or a retrospective look, and that you've got statistical and analytical techniques which are appropriate. And then crucially, if you make a study and you find something, it has to be believable by the people that you offer that data to. And I think we have an incredible problem at the moment across the globe of persuading people that we understand what's going on, that the data that we're describing are credible, and that their life experiences match what the data is saying about them. And that obviously whatever we do in our studies is reproducible and is not just one study in one part of one country, that this is reproducible across the world, or that you have good reasons to and can explain why there is variation. So I'm now going to switch to a bit more detail and go back to that hospital I showed you, the big blue thing with the old hospital in front of it. And the hospital itself is close to that loop in the River Thames that you can see with the purple stuff above it. The purple stuff describes areas of London where the greatest poverty is. And you can see that my part of London, East London, is one of the most deprived, with the greatest area of relatively poor or very poor people. And it has been, I think, at least 200 years worth of East London populations who have often suffered the most in epidemic illness or illness due to industrial pollution, air pollution, and pollution from working in factories, for example, the use of asbestos in the 1940s and 50s. So this is the area we're focusing on this evening. And I want to tell you about two things. The first is moving from a conventional enterprise health record, which you'll all be familiar with. The one we use in East London in the hospitals is called Cerner Millennium. That, as you will all know, is an American company that produces, the company is called Cerner, produces an electronic health record called Millennium. And it has a global footprint. It mostly sells in America, but there's quite a wide use in Europe, wide use in Australia, and in the Middle East as well. In London, using Cerner's Health Information Exchange, we've created something called the East London Patient Record. It's based on IHE standards. the structured data is often encoded in SNOMED, but Cerner also has its own coding system. We have a ton of free text in common with most people. It's a multi-user platform as well, and I'm going to show you what it looks like in a moment. The thing that has really excited me over the last 6 months, and is particularly exciting right now in the middle of this pandemic, is that not only have we connected 4 or 5 hospitals in East London to the East London patient record, or the Health Information Exchange system, we've connected to something like 400 separate general practices, 2 social care organizations, and 2 mental health trusts. And over the last actually month or so, we've now connected that group of healthcare providers in East London to the healthcare providers in South London, so south of the Thames. In North Central London, primary care has also connected up. And in essence, all the GPs in London have connected through this record. And so data that's in a primary care record in London is viewable in my part of London. That's not yet true for all the hospitals, because not all of them use Cerner. Some use Epic, some use their own homegrown systems. But we would expect to see that connectivity grow to cover the entire healthcare system of London within a year to 18 months. And therefore 9 to 10 million people using a variety of healthcare records will be connected up. And then towards the end of this talk, I'm going to talk about how the data in those systems and in the Health Information Exchange are fed into something we've called the Discovery Data Service, which is a data service for health and social care. It's based on, again, international standards, SNOMED on fire. It has a publisher-subscriber model and will, over time, provide research access, and already has a consent model for the use of that data. Gosh, health records are funny things, aren't they? So I'm very familiar to this set of applications, which are part of the Millennium Record. I think if I showed this to an ordinary citizen and said, "That's you," they might say, "Well, that's nothing like me. It's nothing like how I think of what you might have about me," that question of what is in my record. It would be hard to navigate through this set of screens. But we do, and this is the core record power chart that holds the clinical data, and I'm going to begin to take you through that. So the hospital, and I think now very substantial numbers of all of our staff, do create meaningful problem lists that can be certainly understood by most health professionals, and I suspect by most patients in reality, if they could see it. This is a real record. So this is one I grabbed yesterday or the day before when making this set of slides, and you'll see it belongs to somebody who's currently an inpatient in one of our intensive care units, has a disease caused by 2019 nCoV, novel coronavirus. And those of you who are used to the UK edition of SNOMED International will know that that is a UK SNOMED term, which I think is also in the international edition. I don't know for those of you who are in other countries using other editions, whether you'll use something with exactly the same words in it, but this is structured, findable data. A bit unusually, because of the way we've used the record, we also add to the problem list for this visit, for the encounter we're viewing, a SNOMED term for the fact that the patient has had an assessment for venous thromboembolism. You're probably all aware that actually clotting disorders and thrombosis has turned out to be one of the most significant additional complications of having coronavirus, and almost every patient has ended up being anticoagulated with low molecular weight heparins or other drugs to prevent progressive disseminated intravascular coagulation or other clotting events. This patient, in addition, though, has as chronic problems atrial fibrillation, chronic lymphocytic leukemia, hypertension, and one of the ways that Sophie and I make sure that we know what's going on is we also have got our infection control team adding an additional SNOMED code to the chronic problem list because we know that our infection control team are more reliable than our doctors in adding structured data to the problem list. So we know we can find every single patient with COVID-19 who's currently in our hospital. I want you to keep in mind that bit of information about this patient. I also want you to bear in mind this list of SNOMED terms, which is in the chronic history list of the patient. So those of you who are clinical on this call will look at that and go, cool, that's a bit unusual. Maybe those of you just who are thinking, who aren't specialists or whatever, will also think it's a bit odd. It is a mixture, and I think one of the challenges for the data quality question that I put to you in thinking about using real-world data is in this list. So there is no way that an echocardiogram is normally kept in a past history list. An echocardiogram is a procedure. I don't know what was in the mind of that clinician, whether they added echocardiogram to a history list, other than they wanted somehow to signal that this patient had something wrong with their heart and they did a test. You'd expect that to be somewhere else in the listing. There are two other things about curation here. The patient has a leaking valve, a heart valve, listed under mitral regurgitation. And whoever was looking for SNOMED terms with the browser that we use probably put regurgitation in the first case, found a term for regurgitation, and added it in this list. How you curate that is a challenge. Regurgitation can mean almost anything. Throwing up, regurgitating from the back of your throat, your heart valve regurgitating. It's a meaningless medical word, but one that is used in many contexts. And again, why would you put a term for a note summary on a computer, in a note system? Don't ask me, I don't have the answer, and I can't cross-examine the people who are noting. But I emphasize some of this because of that question about data quality in your records. And I hope all of you listening to me and thinking about how you get engaged and engagement in record keeping, in analytics using big data, have systems where you're thinking about how you get either the analytics to remove the froth, or you get better understanding of what it means to note using structured data by your clinicians. I now want to switch to that magical thing, the East London patient record. And this is just a screen grab of our table of contents in our Millennium record. And I've shown an arrow at the thing called the East London patient record. So this is the device that uses IHE standards and takes data from our record, from a GP record, from a mental health hospital, from social care, and makes it available in a single view in any of the health record systems that we have across London in the way that I described. So if I, as a hospital doctor, was interested in what the general practitioner had in their data, in their record, I get this summarized first page, which lists as headings investigations, diagnosis, events, examinations, medications, risk warnings, problems, and procedures. And each of those headings I can open and see the structured data that a general practitioner has added to a patient's record. And one of the super advantages for me as a hospital doctor is I basically get access to a lifelong record for that patient. Most patients in England have had a GP from birth. And for many now in the sort of age band of 30 to 40, will have had a consistent electronic record for anything up to 30, 35 years, life to death type of record. So I now am going to show you what might be in one of these boxes. So I'm going to show you what's in the problem list for that same patient that I showed you what's in their hospital record. So there's some really good news. General practitioner also knows and has in their record now that the patient has a suspected disease caused by 2009 coronavirus. In fact, it's gone in 3 times for any number of reasons, probably because the GP system allows the patient, the doctor to request a test for COVID-19, which might be reflected by this entry. And then they put in, oh, I think this patient, I'm pretty sure has COVID-19 as a suspected. And then he further refines the information as he goes along. You'll see that GPs also, in a sense, abuse the record by not being careful about their data entry. And so we have procedures here in a problem list. Cancer care review, twice over actually, so separated by 3 months. The GP also knows the patient has a form of leukemia. If you flick back your mind back to the hospital list, there is consistency. In fact, the GP, if anything, slightly better than our clinical staff in the hospital, and that he staged the chronic lymphocytic leukemia, whereas my colleagues didn't. There are other procedures here. I think this is great data. So if it sounds as though I'm being critical of my colleagues or critical of the record, I'm not. I think this is great data. We will have to develop analytical techniques that allow us to sift and use this data. We do also need to work with our clinicians to try and get them to use the data fields more consistently. But it is possible to sift and dice and slice and cut this data to be useful and to make a great deal of discovery for the benefit of the people we look after. So a pause here for a second. Where have we got to in London? Because we've got a strategy for what we call the One London programme, which is that we would want ubiquitous data sharing across the entire population that uses London health services. And I think we're very close to getting to that great place and having ubiquitous data sharing for the 9 million people or so who live in London. That probably doesn't include the extra 2 or 3 million who travel in every day when they're allowed to travel and who may use health systems and who live out in the suburbs. But we are very close to a very well-developed sharing system. I hope in a moment I'm about to show you that we also have more than just a start on a normalized data service for health professionals, commissioning agencies, researchers and others to use to uncover health questions and help people to stay well. The one area where I think we haven't really made progress, it's talked about quite a lot. There's a lot going on in the world of patients using health apps and so on, but none of that is used in an integrated and collaborative way between the health services and the citizens themselves or when they become patients. So I think we still have a long way to go before we're using structured data like SNOMED in an understandable and computable way with patients, and where patients feel they own that data and therefore own their health and do something about it. Here is an outline of what the data system built on the combined electronic health records look like. So you'll see that in the top part of the pipeline, that we have publishers from all of the different parts of the health system, GPs, community health, hospitals, and so on. And before the data is allowed to flow down the pipe, we have established data processing agreements and consent to publishing the data with all of those components of the health system. And then we have another tap that, if you like, controls the flow, which is that we've got information governance processes which check that we're complying with GDPR regulations, our own concepts of ethical use of data, and public fora where the public and citizens can comment on our use of data. Then there's something a bit more technical in the pipeline, because the data is now flowing into a cloud-based data system, and where a team of analysts and database experts are normalizing the data, putting that data into publishing databases. And at that point, we have another control valve saying, okay, we've now got data ready to feed out to subscribers for the data. And the subscribers, of course, may be the same people who have fed the data into the system, but it may also be third-party researchers. It might be big pharma looking for data, and the data sharing agreements will be about whether we're providing identified data because the data is being reused in the health record and in the health system for direct care. But it may be de-identified so that it can be used for research purposes. And we've built already a set of application programming interfaces that feed that data to a whole range of different users. So let me take you a little bit on. Where have we got to with that? So at the moment, the database, which involves patients in East London and currently Northwest London general practice, includes about 3.2 million individual people's identifiable data and de-identified where we need it. And the great chunks of it are now modeled and coded using SNOMED CT. So we think that's a substantial and significant achievement. And let me show you, just in the final part of this talk, the kind of thing we've just been using the data for in East London. So not surprisingly, everybody wants to know how and what is happening to COVID infections, both locally and nationally. This data is local. So this is data only for East London. And the two different graphs show you the trend by numbers of patients over the month, the whole of March and the whole of April. And you'll see that I grabbed this yesterday. So the data is fresh up to May the 4th and shows you the daily trend of confirmed COVID-19 patients in the whole of East London. And the right-hand graph shows you a rather higher number of patients who were suspected to have coronavirus. And you'll see it's real data because you see there are chunks in it every 5 days. So weekends, we don't collect data as effectively as we do during the week. And so, but that's in a sense the beauty of real data, and also shows how you have to then work on data quality and data smoothing. I've broken it down a bit because I think there's some things that are interesting, certainly to anybody who lives in East London, but this is the kind of data you might all wish to have about your health system based, I'd like to re-emphasize on data that is real world data extracted from electronic health records today. It's not data put on a clipboard or, you know, done by people entering stuff from a spreadsheet and so on. This is just extracted day by day using analytical techniques from the electronic health record. There's some scary and interesting stuff in this graph. So you'll see that what we've done here is to break it down by areas of East London. So I don't expect any of you to know that East London is made up of different areas, but they are, and they're called Newham, Tower Hamlets, City and Hackney, Wilton Forest, and those are independent commissioning areas which pay for healthcare for the people who live in that council area. And you'll see we have a problem, that the people of Newham appear to have much more coronavirus than even other parts of East London, and really seriously more coronavirus problems than some of the people living further out in wealthier and richer parts of East London. Those are those ones labelled Havering, Redbridge. Brent happens to be in West London, and that data set is incomplete, so I don't think the comparison is real. And we still have to build that data set up. But for East London, this is very revealing about how the infection is spread, how you can relate it to the wealth of the citizenry, and also other underlying problems, which I'll show you in a moment. So I think everybody's aware that coronavirus seems to affect people of minority ethnic backgrounds much more commonly and much more severely than the equivalent white population. So I've now drilled down to the area of Newham only. You'll see that the male-female split that you might expect with more males than females does not seem to be true of this area of London, so slightly more affected females. The age range, I think, shows that this doesn't only affect the elderly. In fact, if anything, there's broad infectivity and confirmation of infection across the age range. And most alarmingly, you'll see that if you're a South Asian living in Newham, you have something like twice the number of infections as the white population. And there is apparently little distinction between the English black population and the white population there. So there's some really interesting, valuable population health data in here for us to work on and think about what we do to protect that population if there is a second phase. There's some nice tools in this that we're growing and developing. This is the same, in a sense, the same data, but shown in a map for Newham. The green area, the green blobs here is where we have testing stations. So we know people are getting tested in parts of this part of London. Not as much as we'd like by any means, but at least we can track it now. And we can begin to see the hotspots of where people are presenting. As it turns out, this is not by either address or postcode or some sort of unique property reference number so that we don't identify individuals. This is actually the general practices in Newham. And so this just shows you that some practices are identifying more patients than others, but it begins to put together a story and a way of dealing with the issues. So one last slide with data in it, because I think again, this is another big challenge for all healthcare systems, and one where the use of SNOMED is absolutely essential. So at a drop of a hat, we've been able to identify and match patients with COVID-19 with their comorbidities. And so you'll see that if you have the misfortune in Newham of having essential hypertension and type 2 diabetes, you have a streamingly higher risk of getting coronavirus and so on. And if you look on the right-hand page, you'll see that you're much more likely to die from it. And so this data, of course, has been widely discussed, I think, on the television, in the press, and so on. But we've got very specific data here that we can begin to tease apart. And I hope that Sophie will give you some feel for how she's beginning to address that as a data scientist. So one last slide, which is, I think this really shows something remarkable about modern healthcare systems, and is very different to the Semley plague stone, because we know things about the people of London which will help us solve this pandemic. And it's based on real world data entered at the point of care, used during the care of that patient, but then used for analytics. The data is multi-layered, as I think I've shown you. And I hope I've shown you that we can get near real-time analytics based on that data. So the slides I showed you are based on data that was only available and added to the health record 2 days ago. I could have got you yesterday's data, as it happens, but that would have left me very little time to make slides for you. It is crucially based on enterprise level single system computing systems. So we are exceptionally lucky in East London in having a universal use of a secondary care system, namely Cerner's Millennium system. And in general, in the primary care system, they use really only one primary care computing system called EMIS. There's a little bit use of another one called System 1, but basically we're putting the data together from a relatively small number of systems using modern standards and using SNOMED in particular. The transformation in discovery means that anything that isn't SNOMED coded is now SNOMED encoded. And Ian knows that he's about to make me a namespace for London so that we can create specific SNOMED codes that are relevant to our practice. And that discovery is also modeled in order to get information back into system on HL7 fire. And I think the thing that's beginning to really be understood by politicians, health providers, doctors, nurses, and I think now patients, is that widening the platform, providing data in this way, using the data in cloud technology so that people can self-serve themselves data, is the road to understanding the problem that we have and finding solutions to it. Thank you very much.
Thank you, Charles.
I've got to get out of this thing now.
Yeah, so if you can unshare your screen, I'm going to pass over.
I've probably talked for far too long, haven't I? But no trouble.
That's okay. You always talk for too long. So I'm going to hand over to Sophie Williams. We'll take questions at the end. So if you have any questions, store them up. We'll have time at the end for questions. So Sophie, I'm going to hand over to you. I'm going to let you introduce yourself because I don't actually know you. So I can't introduce you.
Have you got control back?
I think I can take over the control from you.
You can, good.
Can you see my slides?
Yeah, I can.
Yeah.
Good. Yeah, so my name is Sophie Williams. I work at Barts Health with Charles, and usually I work on a research data science project using data from our electronic health record to see if we can pull out factors that will predict complications in diabetes, specifically diabetic foot disease. But currently I've been helping develop a COVID clinical trial and research database, also derived from our electronic patient records. So I'll tell you a bit mainly about the COVID database, but then also a bit about how I've been doing the clinical data analytics in my main project. So some outline. I'll tell you a bit about the research that's going on at Barts Health around COVID and how we're supporting it with this master data set. Then I'll follow up and tell you a bit about how I'm using SNOMED expression constraint language for clinical analytics, both for defining and categorizing the data to make it in a way that's usable by me and by analysts I work with, and also how I'm using it for statistics. And then I'll finally touch a bit upon some of the text analytics to support this. So within Barts, basically we're getting a lot of requests for use of our patient data. And a lot of these requests are asking for more or less the same data fields, but it's not feasible to kind of produce individual data sets for every single request. And it's also not feasible to just give access to the data warehouse to any researcher, understandably. So our goal has been to prepare a standard data set for all users. And these kind of uses include clinical trials is the priority. So this has been to support enrolling patients and co-enrolling them on the prioritized clinical trial lists, and also to reduce manual data entry when we are sharing the data back to the clinical trials. And so far we're enrolling patients onto 6 of the National Institute for Health Research's prioritized clinical trials. These are Recovery, Remap Cap, Azaric, Genomic, Accord2, and Priest. So some of these are interventional trials, and other ones are just data collection observational studies. Another use of this COVID dataset is for internal audit. So local clinicians and analysts really want to understand the population of COVID patients at Barts, as Charles has touched upon. And we want to understand how outcomes are related to demographics, comorbidities, virus symptoms, and treatments. And finally, for research, so there's a need to share this data set with external researchers and contribute to a lot of the other data collection studies that are going on for either broad or more specific research. There's been specifically a lot of interest in our data set due to the increased attention from Barts kind of being organised in the NHS Nightingale Hospital, which luckily hasn't been needed that much, but it's increased the attention onto Barts. So just briefly, what data is in our Barts Health system. So Barts is one of the largest NHS trusts. It comprises 5 hospitals and 1 temporary field hospital, which is Nightingale, and covers a diverse East London population. So we usually see 2.5 million patients per year. And within the Barts data warehouse, you can see I'm able to pull out most of these patients, tens of millions of encounters, hundreds of millions of clinical events, and again, millions of procedural data. So within the data warehouse, there's both administrative commissioning dataset data, and this goes up for billing purposes and public health purposes. It's mandated that we collect and share this data. Whereas there's also the clinician completed data, which Charles has described to you already, which is mainly SNOMED coded. Data quality really varies between patients and across departments. So patients who frequently attend one of our hospitals have more complete and more filled out problems listing and procedural data. And certain departments kind of uptake the use of electronic health records more than others. There's also differences in the use of SNOMED within different parts of our data warehouse. So ED use the emergency care data sets, which is a subset of SNOMED, and this is coded in concept IDs, whereas most of the rest of our data warehouse, we have the description IDs stored in. So this allows the clinicians to use whichever description is their preferred description, and then it kind of links back to the same SNOMED code. Whereas for most of the analytics I use, I need them in the concept ID form, so I have to map them back. And finally, historical entries contain codes which are now depreciated, so we have to map these codes to more modern and active SNOMED codes so that they can be supported for analysis. So yeah, within the COVID master data sets, there's a full identifiable form, which is used for the internal analytics, and then there's subsets sent out to clinical trials. So this can be a subset which only contains the consented patients, or it can only contain certain fields that are relevant to that study. We also produce a de-identified version, which can be shared with researchers and for external requests. And currently we have, just from patients that visit Barts Health, 7,500 suspected COVID patients, nearly 3,000 COVID positive patients. So they're patients with a confirmed positive lab test. And out of these, 225 are currently enrolled into interventional clinical trials, and many more are in the observational, so non-interventional trials. And in the full data set, we've included demographic details, administrative information on their hospital encounters, comorbidities, which are largely SNOMED coded, symptoms and complications are also mainly SNOMED coded, lab test results are all in there, vital signs, and also any free text documents, which I'll tell you a bit about how we're processing those, which is still ongoing. So included in the data set is both the raw data of all of these things, and also we've done a lot of processing to make it more useful for the trials coordinators. So I'll tell you about the data analytics we've done to process this. We're also linking the data sets to open data sets, including the deprivation data, which Charles has already touched upon, and the primary care data sets, and that's via discovery. So some example extracts you can see this is a patient's problem list. So again, they've got a SARS-CoV, so coronavirus in there. And you can see the problem code here is a SNOMED description ID. You can see the onset date, and you can see it's a confirmed case. And this is raw data, whereas for sharing, we process the data. So one of the fields which is of interest to researchers is previous medical history, and there'll be certain categories that they're interested in. Do they have a diagnosis that fits in, say, for example, a cardiovascular disorder or a hypertensive disorder? So we need to be able to categorize all the codes to have a binary yes, no for each patient, each condition. Also for kind of symptom onset and complications, the date of onset is important. So for things like pneumonia and other symptoms, we either have null, where there's no noted symptom present, or we have the date of the onset, which is really useful for analysis. So a lot of the data is actually in free text documents, and this is otherwise inaccessible unless we perform text analytics, which can enhance the data set. And Bag of Words is a tool used. So we are matching dictionaries to the free text. And you can see in this extract on the left, it's a nursing note. So it contains a list of drug history, allergies, diagnostic results. And by looking for matches to words found in the British National Formulary Medication Dictionary, you can see it's pulled out a few of the medication names may not be perfect, but we haven't started tweaking it yet. And even getting a few terms out is kind of more beneficial than not having them. For putting out medical terms from other free text, we started by using a WHO list, which was picking out far too many words. So it was pulling out words like with and Dean, which I think was the name of the reporting radiographer, which are obviously not useful for us. We're now actually trying out the SNOMED TRUD files, so that has the added benefit of any medical terms that are pulled out, we can match back to SNOMED. So hopefully that will be more successful, but we're still working on that at the moment. And I think there's an average of 10 clinical terms are pulled out per free text. So you can tell that this will immediately enhance the data set even more. And that can be included in all the clinical analytics that we're doing as well. So the way to categorize the, so once we've pulled out a SNOMED term, we want to be able to group it. And the kind of broadest way that we might want to consider it is to pull out anything that's a disease. So a researcher might be interested in, tell me anything that's a disease. But when I last checked, there were 76,000 SNOMED concept IDs that matched anything that is a disease or more specified. So just having that is a bit too broad. We might want to specify it more as we're interested in seeing any disease that has a sudden onset or is a short duration, to look at kind of complications in coronavirus patients. So if we specify we're interested in diseases that have this clinical course, then there are 1,500 SNOMED concept IDs that fit with this. And then we might want to specify further and say, actually, we know that a lot of the complications are affecting areas of the lung. So we can say, we're specifically interested in the interstitial tissue of the lung. And there's 59 SNOMED concept IDs that are a disease that has this finding site. And then if we kind of group these together, then we can find that there's only 9 SNOMED concept IDs that both have a sudden onset or short duration and have this finding site. And one of these is ARDS, or acute respiratory distress syndrome. And you can see here that it is, it's described as being a disease, and it has the following relationships: that it's has associated morphology of edema, it has a finding site of the structure of interstitial tissue of the lung, and the clinical course is sudden onset. So this would be picked up by a query with those kind of relationships specified. And for doing clinical analytics, you can write in expression constraint language these queries to find any SNOMED terms that fit the descriptions that you're interested in, which is really useful for both finding patients that need to tick a lot of boxes to be included in a clinical trial, and for specifying things that are relevant for your specific research questions. And this is due to the structured polyhierarchical form of SNOMED. So when I query SNOMED using ETL, I use a terminology server API. And then this gives me back a table full of SNOMED codes that fit that ETL. And I can just match those back to our larger data sets and use that as a label both for analytics or for future modeling when I do my predictive modeling. So for example, to find codes of diseases with the sudden onset and of short duration, which affect the interstitial tissue of the lung, we could say anything that's more specific than disease. And then you can see here the clinical course and here the finding site. And I found in my experience that it's a bit of a trial and error or an art to writing the ETL queries, because one of the good things about SNOMED is that the clinicians can describe what they want to input into the electronic health record in numerous different ways. So they may not always describe something as a disease. They might use a slightly different term. So I have to make sure I'm including any possible way that they could be describing this term that I'm interested in. And just I've been using the CSIRO onto server tool to help develop my queries. So jumping back on into my diabetic foot disease project, where I've kind of got a bit further with the data analytics. Here's some work we've been doing with a pseudonymized data set, again pulled out of the BART's electronic health records, and this is including diabetes patients, which are 35,000 patients, and we've pulled out basic demographics, diagnoses, procedures, and encounters. And within just this cohort, there's 25,000 unique SNOMED codes. So far too many codes to kind of do any like dictionary search for terms of interest or to pull out your favorite SNOMED codes. It's much easier to use ECL to analyze these. And there's now average of 12 hospital encounters per person. So these diabetes patients are regularly attending the hospital, so they've got quite full health records. And we can just categorize conditions into, I think these are 15 general categories of interest. And I've looked at the onset of disorders compared to the onset of the diabetic foot disease diagnoses. And unsurprisingly, you can see a giant peak of diabetic complication just before the diabetic foot disease. So that's probably covering all the diabetic foot diagnoses. But then you can also see a scattering of cardiovascular problems and infectious diseases, which is probably unsurprising. So this is kind of a good way to get an overview of kind of what's going on in this population of patients. Also, I've been using the SNOMED International Health Data Analytics tool. So this has a statistical test API, which can be used to generate hazard ratios. And to do that, you can define a cohort of patients using ECL, and you can compare the incidence of an outcome, also as an ECL, with different exposures. So I've looked at this population of diabetes patients, and we want to compare outcome in those who have a neuropathy as an exposure and those who have vascular disease. And the outcome of interest is a lower limb amputation. So you can see in patients who get a lower limb amputation, who have a neuropathy, there's a hazard ratio of 2.2, and those with vascular disease, there's a hazard ratio of 10, and these fit with the literature. So if you have vascular disease, you're much more likely to get a lower limb amputation than those without vascular disease. And yeah, there's a link here if you want to try that tool. So yeah, just to conclude, in my experience, we've found that EHR data is generally rich enough to produce data sets to share for data collection in clinical trials. And the de-identify version is a really valuable resource for research using real world data. In addition to the kind of technical side of developing the database, we've had a lot of conversations about how to develop data access rules, prioritization for who should have access to the data, and the best way to host this platform for external access, which can involve both how external people can access the data and the kind of governance around this. SNOMED coded data can easily be categorized using ECL, and by using Snowstorm, we can do some descriptive statistics straight from the dataset. And yeah, so thank you. I'm happy to take any questions.
So thank you, Sophie. So I'll open up to the audience. Does anyone have any questions, either in the chat box or verbally, however you want to do it? Don't all rush at once.
So I'm not going to ask a question, Ian, but there is a question from Vazos in Cyprus saying, can a clinician having no knowledge of ECL do data analytics for the department she works for? And Sophie might wish to answer that one, but I think the simple answer is, if you have knowledge of ECL and you've got access to the data, yes, you can.
Yeah, and just to add, there's a lot of kind of tools available out there to support kind of playing around with your data and getting into ECL. So both the CSIRO Onto server and SNOMED International has some good tools as well.
I think, Ian, there may be a bit of a challenge for you, me, Rory and Kai, which is to sort of expand the Confluence space, giving people a sort of talking space for use of ECL at a practical level in the way that Vassos seems to imply he wants to do in Cyprus. Because I think at the moment it is still a kind of a specialist art that only a few people really use or understand, of which Sophie is one, and she's found a few friends either through her own devices or by introduction, namely Kai and Rory himself. But and of course Peter Hendler in the States. But I think there are some really big opportunities for doing some very interesting work here.
I think I don't disagree. I think the interesting thing for me, being involved in SNOMED for a long time, if we'd had this conversation 3-4 years ago, the big drive then was you could do a lot, but you don't have SNOMED encoded data.
Yeah.
We're now getting to the stage where you do have SNOMED encoded data, and you're almost moving on to the next step of development, if you like. So when you have this data, what do you do with it in terms of getting the biggest bang for your buck, if you like? So getting the most from the data you've got. I do like Sophie's statement about the art, because I wholeheartedly agree with you. Clinicians of any sort are clinicians. They're all individuals and do things in their individualized way. And making sense of that truly is an art. But yes, I don't disagree. I think having a space where we can start that conversation and share some of those artistic nuances is probably not a bad way forward.
And yeah, it definitely requires a lot of kind of checking the data. You can't really just do it from logically. How would I describe this? You have to check this is how they are inputting the data.
Yes.
So you're going to have to work with the clinicians sometimes.
And that's always a challenge, working with clinicians, as we know.
However, I think there is a kind of iterative process where as people realize the importance of doing the data entry a bit more systematically, a bit more consistently, then Sophie will be able to fire back better quality and higher value analytics, and that will be a virtuous circle of improvement. In case anybody was wondering with my presentation what the time scale was, I think it is worth me just emphasizing that we went live with Cerner Millennium on April the 8th, 2008. It's a date burned into my brain because it caused me a lot of personal, mental, and physical pain in trying to get doctors to use the system and so on. And we're now just beyond April the 8th, 2020. So that's 12 years on, and it's still a work in progress to get decent data entry. So this is a long journey. And I'm sure it's everybody's experience on this call. But if you're kind of starting out in the world of point of care data entry using enterprise records, whatever that is, whether it's Epic or Cerner or Allscripts or whatever, something you've made yourself in your garage, the process of getting everybody to do things in a consistent and way that then the analysts and data scientists like Sophie can do is a long journey. It's not an overnight job. I think it is possible to go faster than we went at Barts Health. But let me tell you that one of the things that took an amazingly long time, not surprisingly, in building the Discovery Data Service is simply getting the 400 general practitioners or the general practices in East London to sign data sharing agreements and agree to share their data into the single database. It was much easier for Barts Health as an organization because all it meant is that I signed something. So I signed it for 20,000 employees, and that's easier. But general practitioners are all individual contractors for health, and they all have personal liability in a way that maybe other practitioners don't, for care and for the maintenance of GDPR and data safety. So they take that responsibility incredibly seriously, and it took a long time to get those data sharing agreements into place.
I think the other, I suppose the other aspect is something which Charles, you and I have talked about in the past with Peter and with Jane, is which kind of links to what the question Vassos was asking in some ways. But if you can make the analytics and feed the data back to the clinicians in, whether it's real time, but certainly quickly, your data quality, not surprisingly, will increase exponentially if the clinicians can see the data they're recording and using it. You know, and I, from my past experience, I know I did some work, which I think I've spoken to Charles about in the past, but in the past in the UK, with cancer patients, most of the cancer reviews take place and are driven by public health observatories in the UK. And each hospital in the UK has an annual visit from the Public Health Observatory. And all the cancer clinicians basically feed back their patient data to their peers as part of that process. And one of my jobs in the past was actually to chair those meetings between the Public Health Observatory and the clinicians for the hospital that I worked in. And one particular visit, the skin consultant was feeding back his data, and he just stood up in front of his peers and said, well, actually, this data is all incorrect. And basically effectively went off on one, and was really derogatory about the way the data was collected and analysed and everything else. And the clinician from the Public Health Observatory let him finish, and then just turned around and said, well, actually, that data is your data. And which, so one made him look incredibly stupid in front of his peers, but the serious lesson about that is that once you start sharing data between clinicians, there is a peer review effect that comes into play, either in the sense that you start competing with some of your clinician colleagues to make sure your data is better than others, but at the very least to make sure that your data isn't inaccurate and makes yourself look silly in front of your peers. And having that, a way of feeding that data back quickly. And this was, the example I've just given was way before electronic health records. So this was back in the days of good old clinical audit forms, which took time to analyze and feed back. But now we have the ability to make that data available very quickly and in real time. That's a big important driver. If clinicians can see that data and use it, and and provide it back to them in a usable form, which can help them deliver their care better in terms of better quality, more comprehensive coverage, better understanding. So yes, things will change. It's a brave new world. So, any other questions from anyone? Well, I'd like to thank both presenters for two very interesting talks. Like I said at the start of this, so the meeting is recorded, so we'll make the recording available on the conference site. I'm assuming as you all got here, you've all seen the various blog posts about it, which has a link to the conference page. So on that page will be a recording of the meeting, and also Sophie and Charles will send me your presentations, which I'll post on the conference site. I'd like to thank you, both of you, and thank the audience for attending.
Well, thank you very much, Ian. Yes, we'll send. Well, I'll send mine, and Sophie can decide whether to send hers or not. And can I just, as a way of thanks to you, Ian, for putting this all together, because every time one does one of these things, obviously you do a bit of thinking, you do a bit of kind of data putting together and so on. So that's helpful to me. And therefore there's a kind of plea, I think, to the audience and maybe to friends who might attend. I think Ian and I, and probably Sophie as well, would really appreciate either specific feedback about things you think we missed out or could have done better, and then secondly, thoughts about what you would like to hear about in the future using the same process. So we're very keen to get ideas from you about what would help you.
So yeah, I'd echo that, particularly in terms of future webinars. So one of the things, our focus, if you like, is not necessarily talking about SNOMED for SNOMED's sake in a sense, but more looking at people that are using SNOMED in some ways warts and all. So, you know, not sugarcoating anything, but real world use of SNOMED, and to share those experiences across the community. So yes, if you have, well, either if you want to present, or you know of other presenters with interesting topics, then please contact Charles or myself. That would be excellent. So thank you, everyone. And have a good day or a good evening or a good afternoon, dependent on where you are in the world. And enjoy lockdown. So take care, everyone.
Thank you, Charles and Sophie.
Thanks a lot. Thank you very much.